Hello, everybody. We're going to go ahead and get started. If I can have everybody's attention up front. We want to thank all of you for making an effort to be out with us today for the 2022 annual RHAU conference, or Rural Health Association of Utah. Like many of the communities we serve in Utah, throughout the small towns, we like to get started early. So thanks for being here early today. We hope that you enjoyed the warm breakfast. If you haven't had a chance to grab something yet, everything should be there. If you requested accommodations for food, there should be vegan and gluten-free options set up there for you. We have some excellent speakers lined up today. We really appreciate everybody that has come to help with the conference today and speak. We're thrilled to be here with you today, really excited to get started. And I'd like to turn some time over to our RHAU president, Greg Rosenthal, to give you a little welcome.
Thank you, Casey. If I could take just a moment, I know Casey and the staff of the Rural Health Association of Utah spent a lot of time putting this conference together. Would you join with me in giving them a round of applause? Thank you. We really do appreciate their efforts, not only for this conference, but all the wonderful things that they do with the association to do better rural health in the state of Utah. So I'm Greg Rosenthal. I was the administrator of the Gunnison Valley Hospital in Central Utah for 15 years. And then I joined the Utah Hospital Association about 12 years ago. And in my role with the Utah Hospital Association, I work with all the rural hospitals in the state of Utah. And I would say that the last 2-3 years have been probably the most challenging that I've seen as we've all navigated COVID. And we know the challenge that did to the frontline workers in healthcare, and we all give a shout out of thanks to them. But I'm also mindful of the challenge it was to the leaders in the organizations. And I try to spend a lot of time trying to support and help them, because it was truly a challenging time. Part of the theme of our conference this year is coming back and thriving once again. So we hope that we're back to some level of normalcy as we come out of COVID, and we just express appreciation to everyone involved in healthcare, no matter what your role. We appreciate what you do, and let's go forward together. And please enjoy the conference today. And again, we thank all those that helped.
We want to go through a few just housekeeping items as we're getting started. Restrooms and drinking fountains can be found out the doors here to your right down the hall about halfway. If you are in need of CME credits for today's sessions, there is a sign up in the hallway where you can note down your name and contact information so we can make sure that you're able to get those. During our let's see. I might have skipped a little too far. There we go. During our breakout sessions, we have information tables that line the room. We encourage you to visit those tables and learn about each of these organizations and what they do to serve rural Utah. And we also will be playing a video on the main stage during each of the breaks. We'd like you to, if you have a minute, to sit and watch. It was prepared by the Wayne Community Health Center and showcases a day in the life of a nurse. It's a great video. I've had a chance to view it already, and it really opens your eyes to what that experience is like. Also during the breakouts, there are poster sessions from students representing the University of Utah School of Medicine and the Doctorate of Nurse Practitioner programs, Rocky Vista University's College of Osteopathic Medicine, and Southern Utah University. We encourage you to go and visit these students and learn a little bit about the research that they're doing, and allow them an opportunity to share their hard work with you. We also encourage you at the end of the day to complete our survey to help us with improving the experience for next year. On that survey, you have an opportunity to vote for which poster you felt like was the most informative poster. And the student whose poster wins that will receive a certificate and a Theragun, which is a massage gun. We actually have some Theraguns we're giving away for following our social media as well. So please help us in selecting who that student will be. And we also encourage you to follow the RHAU social media accounts today. There's information in a few different places on what those handles are, including in your program. We will release information throughout the year on those social media accounts about upcoming events and our future RHAU conferences. So we encourage you to jump on there and like those pages if you haven't already and follow. As we get the day started, we'd like to take a few minutes to recognize our conference sponsors. This year's platinum sponsor is the Utah Office of Primary and Rural Health, which is Ashley Moore's office. So we really appreciate Ashley for his support. Our silver sponsorships are the Association of Utah Community Health, better known as OUCH, as well as the Utah Department of Health and Human Services. And then our silver sponsors, sorry, I need a screen in front of me so I can see what's behind me. Our silver sponsors today is Family Healthcare, Crossroads AHEC, Northern Utah AHEC, and the Utah Support Advocates for Recovery Awareness, or USARA. So thank you so much to our sponsors. If we can give them a round of applause. Our sponsors really do a lot to help us make this conference a reality. And we also want to thank Utah Tech University for being such a wonderful host. It takes a lot of different departments on campus and support to be able to make this conference flow smoothly, and they do a great job with that. So thank you to them as well. I'm pleased today to introduce our keynote speaker for this year's RHAU conference, Alan Morgan. Recognized as among the top 100 most influential people in healthcare by Modern Health Magazine, Alan Morgan serves as Chief Executive Officer of the National Rural Health Association. He has more than 31 years experience in health policy at the state and federal level and is one of the nation's leading experts on rural health policy. Mr. Morgan serves as a contributing author for the publications The Handbook of Rural Aging and Rural Populations in Health, and the publication Policies and Politics in Nursing and Healthcare. In addition, his health policy articles have been published in the American Journal of Clinical Medicine, the Journal of Rural Health, and the Journal of Cardiovascular Management, as well as the Journal of Pacing and Clinical. You'll have to help me with this one, Alan, but I believe it's Electrophysiology and Cardio Electrophysiology Review and Laboratory Medicine. Mr. Morgan served as the staff for former U.S. Congressman Dick Nicholas and former Kansas Governor Mike Hayden. Additionally, his past experiences include 10 years as the healthcare lobbyist for the American Society for Clinical Psychologists and Health Rhythm Society and the VHA. Alan holds a bachelor's degree in journalism from the University of Kansas and a master's degree in public administration from George Mason University. Please join me in giving a warm welcome to Mr. Alan Morgan.
Good morning. Can you hear me okay? Your voice louder, right? Welcome, everyone. I'm really happy to be here today and talk about my favorite topic, which is rural health and rural health care. And what a great time to be engaged in rural health policy. So what I'm going to do is set the table for the rest of the conference. So I'm going to talk about what we're seeing in rural health in small towns across the U.S. in the past, in the present, and take a look at where we think it's headed going in the future, because that's where we all should be involved and interested in, right? That's where are we trying to go as a nation when it comes to rural health and rural health care. So this will be a broad look at everything that's happening, which is a lot right now. And as I'm talking, if I'm doing this correctly, you're going to be saying, yeah, I already know that. That's happening. It's happening in our small town. I'm doing my job correctly then, because I'm setting the table that we all have a shared experience. We're a shared journey that we're on when it comes to small towns and communities. But what I'm really interested in is the times that I see the facial expressions like, what are you talking about? That is not what's happening in my small town. That's where I'm interested, because that's the outliers. And as an organization and through the leadership of Casey, and you try to find where are success stories, share those success stories, and then replicate them. And that's what we're doing here for the next 2 days. Great conference for you. I can't decide yet which breakouts that I'm going to. I want to hit all of them. I'm going to touch on everything that you're going to have in those breakouts later on. So let's get right underway. First off, this is our membership map. Can everyone find your dot on the map? Okay, you can't. They're too tiny. But the important thing is just to show the representation we have in Utah for our membership. And it's important for us to bring a lot of different voices together on behalf of small towns at a national level. Now, it's funny, and I'll share this. Everyone here knows this, but I'm just going to highlight it. I like it when I'm in Washington, D.C., and I'm talking about our membership map. And I want you to pay attention to the shape of that map, because it's central to everything that I'm going to be talking about today. When I'm talking about rural health and our membership at the national level, they say, what's going on? Why don't you have members where rural America is? We know why that is, right? Because 90% of those lands are federally owned lands. They're national parks. People don't live there. And the other 10%, of course, is owned by Ted Turner. My jokes get better. Stick with me. Let's start with this. This is an unprecedented year that we're in as a country, and we all have to acknowledge that. Okay, I'm not telling you the truth here. That slide I developed 2 years ago, I just changed the date on it. I use this as a very important date, point that when it comes to healthcare delivery in a rural context, every year is an unprecedented year. If you're at a conference and someone says it's an unprecedented year, either they're lying to you or they don't understand the history of rural health and our healthcare system. In fact, I'm going to use that same slide. I'm only going to change 2 words. Which 2 words do you think I'm going to change? And I'm going to use the same slide for the next decade, and it still will be relevant. The point is why we're here is because it's such a challenging, ever-evolving healthcare sector that we find ourselves in. And that's what makes it professionally rewarding for all of us to be engaged in. All right, let me start with this. So much of what I'm talking about is setting the table of how do we tell authentic stories of what's happening in our small towns? How do we do that? I love this slide because to me, it shares the challenge that we have, right? I mean, because let's be honest, that is a picture of rural Utah. You've got the father looking out into the beautiful sunrise with his daughter, right? And they're looking at the beautiful sunrise, and what do they see? Vulnerable populations, workforce shortages, chronic poverty. Wah, wah, wah. But let's be honest, isn't that every news article you've ever seen or TV show about rural America? Either rural America, according to the national media, is Shangri-La. It's every Hallmark movie that we've ever seen. And we all want to get there as quickly as we can. Or it's a horrible hellhole where everyone's dying and we're trying to overthrow the US government. The truth lies between the two of these. And it's up for us to tell that authentic story. So let me start with audience participation. I know it's a little early in the morning. Show of hands, do we have any students in the audience? Yes. Okay, this is a hot tip just for you. Hopefully this is not the last rural health conference you'll go to. And when you arrive, we're all embracing you with warm arms and sharing with you that you are the future of rural America. Then we'll spend the next 2 days telling you how horrible it is to work in rural America. We are terrible marketers, absolutely terrible marketers. So what I'm going to do to hopefully set the tone and tenor of these 2 days is I'm going to begin today's discussion looking at an asset-based approach to rural communities. What is our strengths? Where do our strengths lie? And what makes us great? I think that's the right way to do it. Yeah, I'm going to talk about the challenges because it's through the challenges that we identify policy solutions to improve our communities. So I'm going to talk about the bad stuff, but I'm going to start with the good stuff just to get us on the right page this morning. If I can get my thing to work. It appears I'm not. Uh-oh. AV help. Need to phone a friend. Let me see if it works out. There we go. Oops, that's even worse. Okay. There we go. So let's start off just talking about what we know about rural America. And it's okay if my presentations don't work because that's just a feeble attempt by my staff to keep me on message. So we'll be all over the board today. Rural matters. Let's start with that. 80% of the land mass, 20% of the US population. We provide the fuel, the food that powers this nation. There is no America without a rural America. It is incredibly important. And as we've seen in national presidential elections, it has an impact on the direction of our country as well, too. Rural is important. Rural does matter. There is a misconception that somehow rural is getting older, the kids are moving away, it's dying off. What are you going to do? This is not true. I just spoke with an NBC reporter yesterday that said, what are we going to do to try to bring people back to rural America? I'm like, what are you talking about? The data does not show that. In fact, over the last 2 years, through the pandemic and the ability for us to work and live wherever we want, we're seeing population increases in rural America. In fact, over the last 7 years, we've seen a steady increase in populations in our communities. It's not dying away. Now, there is one part of the country that's seeing decreased populations, and I'll hit on that later on. And let's be honest, we all know a small town that is an outlier. But I'm talking about at a national level, rural America is growing, number one. Number two, well, it's how we define rural, right? We're talking about a geographic area of the country that when we succeed and we see new businesses coming in, we see young families moving in, we see our healthcare thriving, what happens? We become suburban. Okay, audience participation number two. How many different definitions does the federal government have across its agencies to define rural America? 5, 3, 5, 10, close, 72. According to Dr. Gary Hart, University of North Dakota, the federal government across all of its agencies, HHS, CDC, USDA, 72 different ways of defining rural America. In fact, I teach a course on rural health policy, and I have a 3-hour presentation on rural definitions. It is the most god-awful, painful thing that you could ever imagine. It shouldn't have to be imposed on anyone. We're not going to do that today. I just want to continue through this presentation to reference our membership map, because I think you're going to see the relevance very quickly on that. But the important thing is definitions do matter because it depends on, it helps direct limited federal and state resources. That's a picture of my hometown, actually, Holton, Kansas. Everyone been there? Cultural hub of the Midwest? Yes, 2 in the past, oh my gosh. So you're gonna love this one. So as you see on there, it's Dr. Keen's clinic. It's right outside, actually, in Netawaka. And growing up in Holton, Kansas, it's a small town. It had a 1 stoplight surrounded by 3 Native American reservations. And today it has 3 stoplights surrounded by 3 multi-million-dollar gaming facilities. And these jokes are not resonating with you at all this morning. I don't know what I am doing wrong here. This gets better. So anyway, the point being is now this is a urbanized county, which I explained to Dr. Keen, you got to clean the mud off that damn sign. You're an urban clinician. And you can imagine the joy that Dr. Keen has that someone in the bowels of the federal government thinks that he's an urban physician. That's in no way whatsoever urban America. But that's another point of being. If you actually took the definitions of rural from 1942, use those same definitions to today, you see that in fact, rural is thriving, the populations are increasing, the healthcare access and quality is improving. But because of these ever shrinking definitions, it gives a perception, that perception I talked about, that somehow everything's amiss and we don't do anything, we never make any headway. That is just not the truth at all. Rural matters, number 1. Rural is not shrinking, number 2. Now, number 3, rural quality. I put the next 5 slides in purely out of anger. So stick with me on this. But this last year, I've heard way too many times urban clinicians clutch their pearls and say, what are we going to do about rural quality? What are we going to do about rural quality? I couldn't agree more. According to the Institute of Medicine, we have an unfair competitive advantage when it comes to quality in a rural context. Unfair competitive. Rural America is primary care general surgery. We do it, and we do it extremely well, extremely well. Also, in a rural context, according to the Institute of Medicine, we are more likely to collaborate, to network, to form formal and informal strategic alliances, to get together like we are right today and share best practices. This ability to network, to communicate, to collaborate drives better quality outcomes. And in fact, you see this in this peer-reviewed journal article highlighting higher patient satisfaction metrics among rural communities and rural providers. All right, somewhere out there, we have an urban clinician that's saying, okay, you cherry pick one journal article to try to make a point. You cherried it, and you did patient satisfaction. Okay, how about this one? Okay, so you did two. All right, how about this, this, this? I can do this all day long. I'm not going to this, I'm trying to make a point. I could do a 2-hour presentation using peer-reviewed journal articles demonstrating clearly that rural, when it comes to primary care and general surgery, am I talking fast enough for everyone? Has better quality metrics than urban providers. My staff has asked me to stop saying that. Other associations have as well, but I'm going to continue to say it because when it comes to what our healthcare systems are designed to do, 1, rural matters. 2, rural populations are increasing. 3, rural has great quality care. Boom. All right, now you ready for the bad stuff? I hope that was enough. I hope that was enough to give you a taste that there's great things about rural. And I haven't even talked about the ability to provide leadership within the community. And I will say this, as I get into everything else that is bad about rural healthcare, it is the challenges that actually are our strengths. And I know that sounds like an elevator marketing pitch. But if you have had any organizational theory 101 courses in college, you know small organizations are better designed to innovate and to change and to improve. And that is what we're seeing across the US in hundreds of small towns. We're seeing small clinics and hospitals becoming innovation hubs because of challenges to reimbursement, challenges to workforce, an incredibly difficult patient population. It is forcing innovation. And if you want to see where healthcare is going to be in our nation 20 years from now, you just need to visit a rural hospital today. I know that's kind of crazy, but let's just walk through it then. Let's unpack some of this. Community health workers. That actually is a rural concept. The first policy paper was in the early 80s by our organization 6 months before the American Public Health Association published it. Patient navigators, that concept came from Hazard, Kentucky. Dental health aides, rural Alaska. Telehealth. Okay, so NASA did a lot in telehealth, but what is more rural than Mars? But my point is that we do have to acknowledge the very fragile healthcare system that we have in these rural communities among populations that are most in need of healthcare services. But again, these challenges drive the innovation that we're seeing within our system. Let's talk about that population. And this is going to be the part of the communication, part of the presentation this morning that I really am going to talk about communities. And then I'm going to shift to providers. So let's start with communities. It's frustrating that prior to 1990 or 1992, right in that time frame, life expectancy among rural and urban were similar. They were on the same track. Something happened in our country from 1991 and 1992 that these life expectancy lines diverge. And as you all know, life expectancies continue to increase until the last 3 years in urban America, while it's continued to decrease among rural populations. And the reason behind the declining life expectancy among rural populations is several. I just want to highlight some of the big ones, of course. Obesity rates in rural America. And let me start with this. Does that map look familiar to you? Because the shape of it should. It mirrors the membership map that I showed you earlier. Pay particularly attention to Utah in your state. Okay, huge disclaimer right here, because was that a week and a half ago, I was speaking in Wyoming and a chief nursing officer came up afterwards and said, stop using your obesity map. It's horrible. It doesn't tell an accurate story. And she says, it looks from your map that Wyoming is okay. She said, it is not okay. You are not seeing the patient population I'm seeing coming into our facility. Stop using that map. So I acknowledge that it does look like Utah is spectacular, and that may not be the case in your communities. But it does tell the story. It tells the story that the prevalence of obesity among rural communities is higher than urban. And when you actually pull out socioeconomic status from it, there still is a discrepancy. There's something about our culture, our families, our communities in a rural context that is leading to higher obesity rates. Let's shift now to cancer. I don't have a map for cancer. Trust me, it's the same. But obviously, this is a huge driver. And I want to highlight this because when it comes to cancer in particular, cancer mortality, cancer treatment, it's a horrible witch's brew that's driving these much higher cancer rates. And you know these, I don't want to belabor the fact, I just want to acknowledge transportation, timely availability of early care, preventative care, availability of specialists, environmental factors, all these things play together that really make the point that rural is not a small version of urban. It is a unique healthcare delivery environment. Let me pull it out a little bit. And I have to keep looking back. Normally, I don't need to look at my slides, but I'm afraid I'm going to be on the wrong slide. Pull it out and just look at the prevalence of multiple issues. And again, does this map look familiar? It should, because it's this map. Older, sicker, poor. That is a great elevator line. It's a terrible marketing ploy for us. But that is the case of why rural populations are different. Older, sicker, poor. We see that again and again, and we see it playing out in our rural communities. Okay, let's talk about rural housing. Tip number 2 for you students, if you're ever in a rural health conference and they don't talk about transportation or housing, you are in the wrong conference. You're in the wrong conference. Housing is directly linked to the health of our communities for two reasons. Number one, for you students, once you get out to the community nationwide, the availability of housing for medical professionals is a constant problem. Affordable housing. In fact, we're seeing in many of the nation's small critical access hospitals getting into the housing market, which is what they should be getting into, but on the cost report, this is an allowable charge. That's a little side thing just for the hospital people in here to note on that. But it's a huge problem for finding housing for incoming clinical staff. The real huge issue here, obviously, is the impact on health. Most notably, obviously, behavioral health. Most notably among that, substance abuse and recovery. You can't talk about an effective substance abuse and recovery program without safe and affordable housing. It makes all the difference in the world. Shoot, I went by the slide. That's why I keep looking around. There we go. That is where I want to be. So let's talk about this map right here. And Aaron, this is what I was talking about earlier. I could spend 3 hours on this map. I'm not going to do it, but I do want to highlight some really great takeaways in which you may not be able to see in the back. First, and the most important thing is this data is from 2016. This is the most current data that we have, which actually has opioid and other substance abuse mortality rates. Does that seem crazy to anyone? I mean, didn't something happen in 2020? That's like trying to, as a nation, we're trying to figure out why the dinosaurs went away, and all the data before the meteor shows that they're all doing great. We don't know what happened. We don't know. Having timely and accurate data is of paramount importance. I can't stress this. CDC actually has data up to 2019, but that's okay. We can look at the trend lines, and you all know what's happening in your communities. And this is a good news, bad news, right? This is a success story because we recognize the horrific impact that opioids were having. As a country, we came together, we piled a ton of money at the federal and state levels, and look, we've succeeded in decreasing opioid mortalities among our rural communities. Yay us. We've driven everyone else into every other type of easily available substance abuse we can find. I don't know where these trend lines are, but I think you all do know. We are treating the symptom and not the problem here. The federal government recognizes this, and they make the point that through their federal grants, through the Federal Office of Rural Health Policy, they are flexible in nature. I just want to highlight that this is not a fixed problem. The underlying issue of behavioral health and substance abuse still persist within our communities. And now let me talk about this. And I don't, a hallway discussion later on after when I see, because I'll see a lot of you later on throughout the next day. I sometimes wonder if I should pull this slide out, because everyone in here has been touched by suicides, either your family or your friends, or people you know. It's touched all of us. And it's such a horrible, difficult topic that I don't, it's a tough transition to any presentation, but I just feel because of the prevalence, it needs to be discussed. And there are regional variances on this. And I'm going to explain this map to you because it's of particular importance to this state. And I'm going to look for facial expressions that I'm talking on this and make sure whether it's resonating or not. And what this chart shows, and let me see without looking at my back how well I remember my chart. The bottom line are females and the top are males. And it actually is a look at rurality. Okay, say it with me together, rurality. Can we all agree that's the most difficult word in the human language? Rurality. But this is a look at rurality and making the point, 2 points. There are regional variances, and it shows in the chart, you've got core urban, urban, suburban, rural, frontier. The further you go out into remote, the higher the prevalence the suicides are among our rural communities. What is happening out in the West? Every other map I've shown you shows that the southeast of the US in rural is horrible. They're not here. You are. Why is that? Well, there are no wrong answers because no one knows. That's strange? I cannot believe I'm saying no one knows. Everyone thinks. There's research. And I'm bringing this now because this gets into broader public policy issues. The University of Maine is currently looking at the impact that religion plays on suicides. The thought being it is among highly religious, faith-based communities in the Southeast, that's dampening some of the suicides. If that is the case, and the data proves it, I mean, that's a strategy to do it, yeah. Yeah, yeah. Yes, yes, that is a thought. And let me throw this, and I'm going to look at facial expressions right now. The researcher that pulled this together for me, he said that. He says, Alan, you know exactly what this is. He says it's the gun culture out west and the availability of guns. And that makes sense. But there is peer-reviewed literature that access to guns does this. Now, stick with me because I shared that at the Texas Rural Health Association. That is a response I got in Texas, but I didn't know. And I'm talking about suicides, which is a horrible, horrible topic. And the audience started laughing. I'm like, what the heck? And afterwards, they said, there is no way that those people in Utah have more firearms than us. Well, let's be honest, in Texas, you don't get a driver's license unless you've got 15 ARs. They don't, that doesn't happen. And I got the same response in Tennessee, even worse in Tennessee, which is surprising. You'd think it'd be more in Texas. Again, this is the way I'm thinking about pulling this out, because health policy is, there's health policy, there's funny ha-ha and there's funny boo-hoo. This is funny boo-hoo. And it's because I do think it has that, but there's something else here. I think there's something else here. The impact of veterans, is that on it? Well, Southeast has more veterans. Here's one that could. The suicide rates among American Indian reservations and populations, and that might actually have something on it as well too. Here's what I think actually probably is really driving this, and this gets to much larger issues. University of Tennessee is looking at the accuracy of death certificates. Because you probably all are aware of this, but in the United States, you can be the town mechanic and also the town coroner. There are no guidelines. And in fact, in many communities, that does actually happen. And the thinking being in small, tight-knit communities in the Southeast where everyone knows everyone, if they check that box for suicide, it exempts that family from any life insurance benefits. And they're looking into that. And the thinking behind that, then that gets into much broader issues, right? The accuracy of death certificates that impacts COVID, that impacts everything else. So the relevance in that is very significant. The point that I want to make is, and I want to get on from this, but there still today remains policy questions, important policy questions that are impacting the lives of rural Americans that research is needed to know where we go for that. So this will be a great conversation for all of you later on, especially think about this when you get home. How is this playing out in my community? Where are the policy levers to address that? And so with that, I'm going to shift on to the provider community. And I get this is you all have access to these slides. I'm not going to read the slides, but I put this up here for a really important issue. And that is, I know. We have members here today that work in federally qualified community health centers. And if you don't know about them, they are a fantastic model. They are a great model for rural because they combine a primary care with oral health, with behavioral health, and integrated into a health center. It's a great model. There are roughly 500 of those across the US. There are more than 5,000 rural health clinics, more than 5,000. Now, community health centers are a program, rural health clinics are a payment designation. And why I'm saying this is at the state and federal level, people get confused about this. Please help us out. FQHCs are a fantastic model, but a lot of times policymakers do all their policy just for FQHCs, leaving out more than 5,000 rural health clinics. Over half are provider-based, attached to rural hospitals. So just as a level setting on that, let's talk about nationwide the financial stability of rural hospitals today. And this is a story everyone knows. This has been the best 2 years for rural health. Everyone feel that way? Yeah. Well, the data shows it has been. We've only had 2 rural hospitals closed so far this year, which is spectacular. We only had 2 closed last year, one in Kansas and one in Missouri. That's phenomenal. We have had over 140 rural hospitals closed over the last decades, over 140 closed. The pandemic has actually stabilized the rural healthcare system, which is great news. And it's always difficult for me now when the media ask about that, because that really is yesterday. This is today. almost half of our nation's rural hospitals currently are operating at a loss. That is no way to do a business. That is not sustainable going ahead. It simply is not. And you should be asking, why are you talking about this? Do you not see your own map? I mean, you don't have a problem with rural hospital closures. That's what's happened in the past. And I'm really, although I'm talking about rural hospitals, this is central to everything you're going to cover, what I'm talking about in the next few slides. This is a look at the past. And you can see most of these have closed in the Southeast. I think I earlier mentioned that the Southeast is where the health status is the worst as well, too. So this is the chart which you should be concerned with. Uninsured. And now you see your state lit up. This is a look at the future. This is data applied to that. Now you see your state lit up. Now you see your state lit up. Okay, this next slide is the master key to unlock what I'm trying to say about. This actually shows where these rural hospitals have closed over the last decade. And it gets back to my opening statement today. Rural America is increasing in population with the exception of one geographic area, which happens to be Western North Dakota, South Dakota, Nebraska, and Kansas. Population is decreasing during that slither. There is a proposal out, it's called Buffalo Commons. As everyone depopulates, we just populate them with bison instead, which gets back to my Ted Turner joke, which no one found funny. So I'm going to keep going at this point. But the reason why I'm sharing this is in DC, it gets me so angry, and it gets me so angry when I'm talking to the media. Well, you know why these rural hospitals close, and it's volume. They just don't have volume. You can't keep a hospital open. They don't have volume. It's probably bad management too. No, it's not. It is, if that was the case, every one of these rural hospitals would be happening in Western North Dakota, South Dakota, Nebraska. We've had two close, only two close. Volume is not the driver. It is our uninsured population. What we've done as a nation is we have clustered in hundreds of small towns a population most in need of health services with the inability to pay, and we're expecting rural hospitals to pick up the tab. And it is a non-sustainable business model. It's not the population, it's not the management, it's the clustering of high needs patients with an inability to pay. And the data shows this. That's what's happening. Okay, we're among family and friends here. Show of hands, all the media in the room. Good. Yeah, it's more complex than that. There are many factors. We all know that. What I'm sharing with you is the communication tool when we're talking to our policy leaders, right? That's what we're talking about, communication. How do we tell our story? But it does make a nice story, and it's an accurate story. The true story is much difficult. There's a lot of issues, and obviously the pandemic as well too. This highlights the need, and I'm going to make the point now that we need new payment models. We need new provider types. And I'll come back. This is the future. I'm just making that marker right now. So now let's do a hard shift. Let's talk about COVID. I don't want to talk about COVID. You don't want to hear about COVID. Most people in your communities don't want to hear about COVID in 2020. I'm not going to talk about COVID. But what I do think is helpful in the purpose of this, and the theme of this conference is coming out of this and how do we move forward? So for me, I think, what are the lessons learned from the last 2 years that we can apply going forward from our community standpoint? What are good lessons out of this? And to me, the best lesson that we can take away and the best thing I can share is public perception drives public policy. Public perception drives public policy. If you want to improve the status of healthcare in your communities, you have to get the community behind you. That means we have to tell our authentic story to the media. I know no one wants to talk to the media. I don't want to talk to the media. But it's the way we tell our story. You have to be willing to talk to the media, number one. Number two, the most important thing I will tell you all day. The quickest way to get yourself fired from any job is to talk to the media. Okay, this is a funny slide. This has been the last 2 years of living dangerously for me, but it makes an important point and a key takeaway. Rural health is nonpartisan. Rural health is nonpartisan. Last 2 years, I've been a talking head. I've been on Fox News, CNN, MSNBC. I've been on One America more times than I can count. For those of you in the audience that do know One America, I've been a talking head for rural, not a talking head for a political party. We have to keep rural health nonpartisan. We have to keep rural health partisan. We have to tell our story. I was attempting my best to tell our story of what's happening in rural communities, the impact on rural providers, and the impact on life expectancy. I did a terrible job. I failed miserably. I feel like I could use this one slide and do a whole presentation because I find it hard to believe. This is what happens when you put an older, sicker, poorer population clustered in a community with hospitals that are designed for primary care and general surgery in a community that in many cases are not following public health measures. It is what it is and you get what you get. But this next slide, I'm interested in your take on my next slide. It's a chart. And I think it is a horrible story for rural communities. I think it's a wonderful story for rural hospitals. How could that be? A horrible story for rural communities, a wonderful story for rural hospitals. Do you all see in this slide what I see? I keep having to look back and make sure it's not a picture of a cow or a cat or something else. Do you see what I see? This is mortality, rural, urban, over the last 2 years. Okay, here's what I see. I want to give you time to try to see if you see the pattern. Rural hospitals were never designed for a global pandemic. Once you have a high needs patient, you transfer. The policy is transfer. Primary care, general surgery, better quality, better quality, better quality. Despite that, throughout the last 2 years, we've seen mortality, rural and urban, the same, except during the surges. We have a problem with our transfer policies when the urban facilities are filled up. That's what this demonstrates. Our rural hospitals, despite not being designed for this, succeeded beyond expectations. That's a huge testament to the ability to modify processes to keep your community safe. The federal government does recognize this, and you've got 3 different agencies now are looking at how do we improve transfer policies. I can tell you it's not going to end well. It's the federal government. What are you going to do? I like doing that back to them. One thing we have seen is just the impact the last 2 years have had on workforce. And workforce. Nationwide, the top tier issue in rural communities today is behavioral health. The top tier issue within the walls of the hospital is workforce. And we did a survey of our membership last fall and this spring. We wanted to know what was behind and driving a lot of this because the media was portraying it as people are burnt out and no one wants to get vaccinated, so they're leaving the industry. Our survey shows that's not true. Our survey, which I wish would have been the case because that's pretty easy to address. In fact, the problem is our staff, most notably nursing staff, are leaving for higher paying jobs. That's much more difficult to address going forward. This last 2 years has really put the pressure on our workforce. 48%, almost half, are leaving for higher paid jobs. And you see down here, way on down there, unwillingness to comply with vaccine mandate, pandemic burnout, not so much. But again, let's use actual data and let's actually survey people to find out what's going on instead of just going with what sounds correct. That's a novel indication, I realize that. So this is the point with, I put on my CEO hat of the National Rural Health Association. I say, there it is, we have your solution. That's not the solution. I'm not supposed to say that, but everyone recognizes that we need to have legislation to promote repaying student loans and other mechanisms to increase our pipeline. Yeah, that's not what the problem is. And let's talk about the problem. Let's talk about the real problem. The real problem is how do we find nursing and clinicians in the US? Well, we take the kids with the highest scores, right? They take the kids with the highest scores. It just so happens the vast majority of these kids with high scores are upper income kids from urban areas, predominantly white. And then we train them in urban teaching areas. And then we're dumbfounded. They don't want to go work in rural Utah. Who knew? Who knew? And literally yesterday I talked to a reporter who said, how do we fix what's wrong with rural? You don't fix there's nothing wrong with rural. We're attracting the wrong kids. And that's why rural residency training programs, grow your own programs, trying to communicate to our kids that there's a place for you within your community. That really is the way that's a long-term solution. There are short-term solutions right now. The federal government needs to pump more money in this situation. There are longer-term situations. Rural residency training programs are a great, great resource. But at the end of the day, it's really about us doing a better job attracting our own kids to work in a rural context. Okay, updates for Congress. This is going to be very short. Congress isn't doing anything. See, the jokes are getting better, aren't they? All right. Well, although they're not doing anything, this next 2 weeks are really important. That's the reason why I'm still talking about this and I'm still staying directly on time. If Casey's worried out there, no, I'm on time. So, Save Rural Hospitals Act. What we've done is we've worked with Congress. We have a Republican and Democrat co-sponsor. This is a fine menu at a good restaurant. You're not going to eat everything on the menu, but we're hopeful that Congress will pick some great items. And we put everything in here. Save Rural Hospitals Act. I do want to point out, I talked about rural health clinics earlier. We're promoting legislation that would actually provide grant funding to rural health clinics to include behavioral health in a telehealth capacity, because we want to make sure that rural health clinics are able to address that issue as well. I can't talk about a program without talking about the 340B drug program. We are very hopeful that Congress grants additional authority to the Health Resources Services Administration to implement this important program. And if you have questions about this, I'm happy to talk with this because this is a whole separate presentation. I can't tell you how important the 340B program is to safety net providers. It's taking up most of my time these days. But the reason why I hit 340B, rural health clinics, and the Save Rural Hospitals Act is because of this. And here's where the part where I actually talk about politics today. As you may have known from CNN or MSNBC or Nickelodeon, the Republicans have assumed control of the House, just barely. Democrats have barely control of the Senate. We'll see coming up shortly in Georgia. But it's changed the dynamic. 3 months ago, we thought there was going to be a red wave. And if there was a red wave, then nothing was going to happen this year. It was all going to put off to next year so the Republicans could control the spending and where we're headed as a country. That didn't happen. In Washington, D.C., Republicans do not trust Representative McCarthy to actually push stuff through a painfully divided House next year. So Republicans and Democrats, instead of doing a continuing resolution, which would just push all these funding measures forward, which they have to do, they're now going to try to push through an omnibus bill. And for those of you that don't follow closely, an omnibus bill is like a big rusty truck driving through Congress. And the National Rural Health Association and every other organization is trying to shovel as much crap into the bed of that truck as we can before it drives on through Congress. That sounded better in my head. But that's why you should be getting emails right now. Please contact your member of Congress. Tell them to make sure you protect and enhance rural America because they have to pass this appropriations. They're going to push in every other provision that they can think of. The next 2 weeks is critical. I know this sounds terrible, but this is how it works because Congress has the inability in the best of times to pass any legislation. They only run through giant rusty trucks. And again, I really regret talking about this. So let's talk about telehealth. I'm going to wrap up this talking about telehealth, and I hope it makes sense of why I'm talking about this. We all know that telehealth has flourished during the pandemic, right? Right, it has. It has. If I say that enough, does it make it true? This is what we were promised. This is what I was promised. I was promised this. I was promised this, the flying cars and the robots that weren't circular. This represents, you know this. When people talk about telehealth, they do surveys of telehealth, and I'm not aware currently of a rural hospital that doesn't employ teleradiology. I'm not aware of a rural hospital that doesn't do teleconsultations. Gosh, telebehavioral health we talked about. Gosh, teledentistry is now expanding in many states. And I haven't even touched on telepharmacy. But what we are talking about is that primary care intervention from the hospital or clinic into the patient's home. That's what I'm talking about. That's what we're trying to hit for. And this next slide, I'm going to be looking at facial expressions. Right here. On your left is the telehealth experience pre-COVID, during the height of COVID, post-COVID. On your right is the rural experience with telehealth. Nuts. I was hopeful to see a whole bunch of your slides are off. And just like in every other state, I see people nodding their heads. Telehealth is not the solution. There is no path forward for rural health without the implementation and integration of telehealth. This is a horrible slide. This is a horrible slide. When I shared this with the Office of Telemedicine Advancement, they said, Alan, your chart is off. My chart is not off. They subsequently have done a chart, and lo and behold, my chart's right. Urban America has seen a renaissance in telehealth. Rural has not. That is exactly why we're trying to push it by all means possible to have additional legislation to, at the very least, extend the public health emergency provisions for this. What are the barriers for this? Let me tick off what I'm hearing from our members, which is all over the board, as you might imagine. So I just look for facial expressions to see whether you think I hit the mark on this or not. Number one, broadband. Yep, broadband. Number two, reimbursement. It's usually the rural health clinics. It's like, hey, it's a reimbursement out, and that's the reason why it's not. Number three, community and clinician adoption. Yeah, I hear that a lot as well too. I hear all the time from our members, like, our community wants to be in and see me face to face. They don't want to do it from telehealth standpoint. I think all these are legitimate barriers. I think they all need to be processed going ahead. But why is this important when I said there's no path forward? Because every new payment model, every new provider type has a high reliance on telehealth going ahead. If rural is not adopting this, the path forward is increasingly difficult. In the payment rule, and I'm wrapping up here now, I know I'm just a tiny bit late. In the payment rule, there is this push towards away from heads and beds towards population health. And there's a push towards moving towards global budgeting, which works in a rural context. I have no idea how global budgeting will work in an urban context, but it is looking at the past 3 years of healthcare expenditures and revenue, providing a guaranteed payment out to the rural hospital with the ability to adjust for clinicians leaving, for flu seasons. This is currently being done in Pennsylvania, in Maryland. It has a potential. It has a high reliance on telehealth. And crazy enough, for the first time in 20 years, I get to talk about a new model type. I'm not going to talk much, but this is a new concept, and this is not a new provider type for every community. If you're a community and your average daily census in your hospital is 1 to 5, I think this is something you should look for. Every state office of rural health will have funding to do a financial analysis of this going ahead. You should definitely contact the state office of rural health if you have that low daily census. What this does, it creates 24/7 emergency room services, no inpatients. 24/7 emergency room service, no inpatients. And you might say, well, isn't this just a freestanding ER? No, it's not. And freestanding ERs work great in urban areas because they have volume, They do not work in rural areas at all. The surprising thing, the federal government is going to pay out $3 million a year to each rural hospital to subsidize its emergency room service. Now, you have to have state regulations in place to make this happen. This technically could go live in January 1. It's not going to happen because every hospital is going to want to do the financial analysis, number one. Number two, every state needs to have it in place. Some states are a little bit behind. Texas indicated they're not going to have it ready until 2025. And in the meantime, we have rural hospitals closing daily. But what you have here is a recognition of the changing environment in rural, of a shift towards outpatient care, a shift towards networking between rural providers and urban providers, especially for specialty care. You're seeing the future of rural health. So, wow, that's a lot of ground. I talk exceedingly fast today. I've covered about every area. Didn't really talk about oral health, but a little bit. And so what this does is hopefully tee up a lot of questions for you. More importantly, hopefully this tees up a lot of answers for you. So answers you can share with me. So in the remaining 10 minutes of my time, I did actually time this out okay. Questions from the audience, observations, what did I forget to cover in today's discussion? Anyone? Anyone? Yes. Oh, yeah. Thank you. Good. So let me restate the question. I'll watch to see whether I got it. Is this shift in care away from heads in beds to population health? Yeah. So the problem that we have currently in the current payment system is it is driven by volume. But the problem with volume is that when your patient population has high needs and ability to pay, we have rural hospitals closing. So the concept is the elusive search for population health, public health, which we've all wanted to do, but no one wants to pay for it. And so now what you're seeing at the federal level in grant programs is this shift towards how do we pay hospital CEOs and clinicians to keep their patients healthy and out of the hospital in the first place? How do we shift the CEO's role of walking down to make sure that there are heads in beds to the CEO of a rural hospital partnering with Meals on Wheels, the community center, other partners to make sure that rural residents are empowered to take care of their own health care? Are you providing as simple as fitness devices to make sure that they have the tools necessary to take control of their own health? You can't, if you're in a rural hospital and you do a great program of immunizations for flu, you've succeeded, your community is healthy, and your beds are completely empty. And so you've succeeded at putting your hospital at risk for closure. So what we're trying to do is, as a nation now, is how do we do that payment structure to pay clinicians to keep people healthy? And you see that in chronic care management, you see that in accountable care organizations, you see it in global budgeting. It's all this push towards how do we change the nature of how we're doing healthcare, which sounds ridiculous because that's the reason why we all get into this, right? We don't get into this to see how many people we can shove into a hospital room. We get into this to help people, to treat people, but the payment mechanisms are not currently aligned. So in a rural context, that has to happen, number one. If we make that happen and we address the workforce, we can arrest the declining life expectancies among populations. And that's why you have to have a payment reform going ahead. At the same time, you have new provider model types going ahead. Those two things have to go hand in hand. They can't go independently. And you are seeing this. The important thing is it's happening very quickly in rural areas, and I think that we're going to be the ones to find the path forward for the rest of the country to replicate. That is a very optimistic look at the future. I should stop right there. Any other questions? That's okay. I'm going to be here the rest of the day. I haven't decided which breakouts I'm going to be in, but just grab me in the hall and say, that was off. Oh, that was right on the mark. You don't know what you're talking about. I'll take it all. Thank you very much. Go roll.
Alan. Before Alan steps off, we have a thank you for speaking today. Thanks so much. You too. Okay, we're gonna move into our break now. Thank you, Alan. That's really powerful information. Thank you so much for traveling in. Alan came all the way from Washington, DC last night to be here with us today, so. We've reached the first breakout for the conference session, the first break. The breaks are 15 minutes. During that time, we encourage you to visit our information tables around the exterior of the room. And also just a reminder that we have students out in the hallway presenting their research. Please go and visit them and listen to them a little bit as well. And then we will be playing our video from Wayne Community Health Center on the screen during the breakout. We encourage you also, again, to follow our social media for RHAU. Throughout the year, we'll send out resources, helpful information, upcoming events, and then as we move into next year's conference, there'll be information throughout the year as we lead up to that. And then just a reminder as well that if you like or share any of the pages today, it enters you in for a chance to win one of our $400 Theraguns. So make sure that you do that. And then at the conclusion of the break, we'll have our first breakout session. You can find the breakout session options in your book. The conference rooms are directly behind that wall, and just down past the bathrooms down this hallway to your right, or where each of those are located. If you're struggling finding a room, find one of our staff with a name tag and they can help you find where you're supposed to be. So enjoy your break, and then we'll be back at it here at 9:30 with the first breakout session.
In a city, you're generally just one next or on residential. But here we need to a lot. It's not just. You have a whole bunch. It's not. So it's so Thank you for this. For so much support. It's extremely. I don't talk on the basis. You guys have the rest. We'll see something. Later that meetings. It will all better. But independent. So, person. Yeah, pretty exciting time runs. Non-things, and that's important. Getting to go around. You know, we should work. Eventually. They really. Very well. Encouraging you to go out, encouraging you to support and really want to. That's so important. It's great. You don't want that in the world.